Good afternoon. I'm Dr. Subramanieshwar Rao, thanking the President and the Governing Council of Association of Surgeons of India for bestowing this honor of moderating this month's webinar. I appreciate this particular initiative of ASI, which would reach and benefit surgeons all over the country and elsewhere. These webinars are now a regular feature and would be done between 3:30 and 5 p.m. every third Wednesday of the month. I would not need to stress the importance of learning about breast healthcare and benign breast disease. It's a very common physical and psychosocial problem, especially in young women. Speaking on this topic today is none other than the celebrated breast surgeon, Dr. Raghuram. He has been trained in breast surgery in UK and has the unique distinction of holding fellowships of all the four Royal College of Surgeons of UK. He is also the founder of Usha Lakshmi Breast Cancer Foundation, through which he has championed the cause of breast care and breast cancer awareness in the country. He has been honored with the prestigious Padma Shri in 2015 and is also a recipient of many other awards, including BC Roy Award in 2016. This webinar is being run by a generous grant from Healthium, and it would be an interactive session. I request the audience to go online and ask questions to the speaker while he is speaking and after he completes his lecture, or make comments, and also advise the organizers about the future conduct of this webinar. Now I request Dr. Raghuram to take you through the gamut of benign breast diseases, what to do and what not to do. Thank you.
My heartfelt gratitude to Dr. Subramanieshwar Rao for his very kind words of introduction. October is world over recognized as International Breast Cancer Awareness Month, and I'd like to begin my presentation by paying tribute and saluting the breast cancer conquerors in their resolve to fight breast cancer. On the right side of the screen, you will see a patient of mine who has come from the US, recently underwent surgery, and is currently undergoing chemotherapy. The picture on your left, you will see the world badminton champion Sindhu launching the world's first life-size augmented reality for breast cancer awareness, which is being championed by Usha Lakshmi Breast Cancer Foundation. The aims of my presentation today are essentially threefold. Firstly, to outline the assessment and evaluation of a breast lesion, to highlight the ABCs in the evaluation of benign breast disease, and to outline the basic principles in breast cancer management. And the focus shall always remain on basics. The assessment and evaluation of a breast lesion aims for accurate diagnosis. As 9 out of 10 breast health issues are benign, the essential component would be to reassure the vast majority of women who are worried because they think they have cancer, but in fact, they are well because 9 out of 10 breast health issues are benign. This is a common scenario that we encounter. A lady finds a lump in her breast and reports to her doctor. She would then be referred for a mammogram, which may or may not happen on the same day. And even if it happens, the result is usually informed when the patient leaves the hospital or the patient has to return back, in fact, for her report. There is huge variation in breast imaging reporting because of the fact that we have very few dedicated breast radiologists in our country. And finally, the surgeon comes into the picture for assessment. This must change. The aims of breast assessment are to obtain a definitive diagnosis in a timely way. There should be only 3 outcomes. Either there is no problem, either there is a diagnosis of a benign lesion, or there is a diagnosis of cancer. And assessment should end at diagnosis and not before. How do we evaluate? The right answer is triple assessment. How can this be achieved? Through a multidisciplinary approach. In fact, multidisciplinary care was very first time recognized in the management of breast health issues. And we know for a fact that multidisciplinary care improves diagnostic accuracy, clinical effectiveness, reduces morbidity, and raises standards. We should all be aware that no one can whistle a symphony. It in fact takes a whole orchestra to play it. The core team, the core multidisciplinary team in the evaluation of any breast health issue comprises of a surgeon, a radiologist, and a pathologist. Just as a stethoscope is essential for a physician or a cardiologist, for a surgeon practicing breast diseases, his or her stethoscope is a good breast radiologist and a good breast pathologist. Without this core team, one cannot deliver an effective breast health care. So it's always important, and I always believe in the fact that you hire character and train skill and ensure that your entire multidisciplinary team is skilled and delivers the best possible care to the patient. The triple assessment comprises of history and clinical breast examination, which is the first component, imaging, which is a combination of mammography and ultrasound scan, and thirdly, an ultrasound guided core needle biopsy. I'd like to emphasize here that FNA is no longer considered to be the standard of care in the evaluation of a solid breast lesion. Careful use of imaging and clinical breast examination combined with aggressive use of needle biopsy ensures that the patient anxiety can be kept to a bare minimum, and also minimum number of women go under the knife for surgery for benign breast disease. So the first component of the triple assessment, history. As you can see from this slide, the relative contribution of history, physical examination, and investigations that guide the final diagnosis. 90% of the diagnosis can be obtained with a good history and examination, and only 9% contributes to obtaining a final diagnosis. So the first component of triple assessment is to take a good history and always listen to the patient. Naturally, patients get upset when doctors fail with words, and good listening is the best diagnostic weapon. As you can see in this cartoon, the doctor is sitting and you can see the patient sitting at the edge of the chair. And as you can see, the doctor is talking down to the patient. There is absolutely no communication here. And you can see in this cartoon, the doctor is listening to his patient. And so it's very important to have big, huge ears and listen to the patient and take a good history. And listening is in fact more important than talking. And in giving patients time and in listening to them, doctors will find some of the real rewards of medicine. The first component of triple assessment comprises of taking a good history, communicating with the patient, and also clinical breast examination. It's always important to examine the patient properly in the sitting posture and in the lying down posture, and particularly in the evaluation of breast pain, it's important to roll the patient to the side and lift the breast away from the chest wall, which actually helps in distinguishing between breast pain, a true breast pain, and a chest wall pain. The second component of triple assessment is breast imaging, which is a combination of bilateral mammogram and ultrasound scan of the breasts. Is imaging essential for the evaluation of breast lump? The answer is an emphatic yes. The third component of the triple assessment is an image-guided biopsy. As you can see, this is an ultrasound scan of the breast demonstrating a fibroadenoma and a needle in the fibroadenoma. An ultrasound-guided core needle biopsy is being performed. Why a core needle biopsy? Because clinical breast examination and imaging cannot reliably distinguish between benign and a malignant breast disease, and a definitive diagnosis of benign breast disease avoids unnecessary surgery. And I'd not like to go into too much detail, but just to emphasize that the absolute sensitivity, the complete sensitivity, the specificity, the positive predictive value is almost 100% with core needle biopsy, with a false positive rate, if it's done properly under image guidance, to be 0%. So the standard of care in the evaluation of a solid breast lesion in this day and age is an image-guided core needle biopsy. It's very straightforward, it's very simple, and it's very essential that we switch from an FNA to an ultrasound-guided core needle biopsy in the evaluation of a solid breast lesion. I'd now like to just focus on a couple of questions that the patient might have. Doctor, the mammogram is usually associated with a radiation hazard. Is that true? In fact, it's a myth. Mammography causing radiation hazard is a myth. The radiation from mammography is very small, so small that it is less than an exposure to a dental X-ray. And this is very essential to inform the patient when she raises a question like this. The second question that many times patients ask, Doctor, is mammography painful? Yes, it would be painful if it's not done properly. And it's important to train your radiographer to reassure the patient, because many times that's the first port of call, many times for the patient to see a radiographer. So it's very important to train your radiographer in communication skills. It's important to calm the patient, and it's important to position the patient properly. And if it's done properly, then mammography is not painful. And in this day and age of full field digital mammography, there is even less discomfort and even less radiation. The other question from the patient, Doctor, is mammography 100% accurate? No test is 100% accurate, and mammograms, although they are the best way of detecting cancers early, like other screening tests, it's not perfect, and the accuracy of mammography is around 85%. And the reasons are, some cancers are very difficult to see on mammogram. Some cancers, even though they are there, cannot be seen on mammogram. Some cancers, even though they are there, cannot be seen at all on mammogram, particularly lobular cancers. And finally, the person reading the mammogram can potentially miss the cancer. Some practical points to remember in advising your patients. It's important to inform your radiographer, and it's important also to be aware that before a lady goes for a mammogram, she should not apply any skin lotions. There should not be any deodorants, no powders, because they mimic microcalcifications. And many a times when we see patients with a mammogram showing calcifications and the report says clinically correlate, there is nothing that you can do to clinically correlate. It's important to avoid applying skin lotions, avoid deodorants and powders before a mammography is done, because they can mimic microcalcification. And of course, as I have been emphasizing during the course of this presentation, it's important to train your team. And it's also important to train your radiographer, attention to detail, not just how she positions the patient, but also because that is the first port of call for a patient when she comes for a mammography many a times. It's important for her to be trained in effective communication skills and in counseling the patient and in calming the patient down before the mammography is in fact done. Radiographer training is very important, because if the patient is not positioned well, you can miss lesions. You can very faintly see a lesion in the left breast on CC view here. You can't see it at all in the MLO view. And in a year's time, when she presented to us, you can see this is a mammography done, a speculated lesion in the left breast, which has been missed. So it's very important to train your radiographer to position the patient properly. These are all small points, or they appear to be small points, but these are all very important practical points to remember. The second component of my presentation, having touched upon the importance of triple assessment, is to highlight the ABCs in the evaluation of benign breast disease. The expectation that a surgeon's role is only in the management of breast cancer has long disappeared, because benign breast disease is associated with considerable morbidity and anxiety. And effective treatment lies in accurate diagnosis and counseling. And I'd like to bring back the concept of reassuring the worried well, because the vast majority of breast lesions are benign. The commonest complaint that someone presents is mastalgia, cyclical and non-cyclical. Chest wall pain is in fact not mastalgia. And I'd like to reiterate that if you roll the patient to the side and lift the breast away from the chest wall, it's very easy to distinguish between true breast pain and chest wall pain. Triple assessment is essential because 5% of breast cancers can present with breast pain. And it's very important to distinguish between true breast pain and referred pain. All one needs to know, as I mentioned earlier, is to roll the patient to the side and lift the breast away from the chest wall, and it's very easy to distinguish between true breast pain and chest wall pain with this maneuver. What is required is reassurance, advising the lady to wear a correct fitting bra, and very rarely prescribe tamoxifen, which is given in half the dose for a short period of time, or an NSAID gel. And what should not be done is giving evening primrose oil or danazol. In fact, there have been many randomized controlled trials which have shown that evening primrose oil does not work. From time to time in my presentation, you will see various monuments and buildings illuminated in pink. This is the beautiful Buddha statue in the center of Hussain Sagar Lake, which separates Hyderabad from Secunderabad, illuminated in pink during this month. Fibroadenoma. This is again a common presentation in young women. This is a mammogram which shows typical popcorn microcalcifications. This is an ultrasound scan. It's oval, smooth, internal echoes, partial transmission, edge shadowing. Just simply cannot be missed. And what is to be done? Should FNA be done or excision? The answer is no. What should be done is an ultrasound guided core needle biopsy, and we always take a picture when this procedure is being done so that we can show it to the patient and reassure the patient that she does not need surgery. What is to be done? Reassurance, reassurance, and reassurance. Once you take a picture of the fibroadenoma and the needle in the fibroadenoma, it's very easy to counsel the patient and explain to the patient that this is not a cancer and this will not lead to a cancer, and this can always be followed up. Excision is advised only when it is very large or it's causing discomfort, or the patient says, "Doctor, I don't like the feeling of this lump in my breast. I want to get it removed." That's the only time you want to excise it, unless it's very large, of course. And in this day and age, there is vacuum-assisted biopsy, and vacuum-assisted biopsy is a technique that is used to excise the fibroadenoma under local anesthesia in an office setting. And you can see this fibroadenoma, which is being excised with vacuum-assisted biopsy. As you can see, it takes multiple cores, and this is a procedure which takes roughly about 15 minutes to excise a fibroadenoma. This does not require general anesthesia. This does not require hospital admission, and this is done as an office procedure. The patient comes in, she gets the procedure done. There is a period of waiting after the procedure just for observation to see if there is any hematoma which is developing, and the patient is sent home in a couple of hours' time. So this is the same lesion after excision. This is an ultrasound picture which shows that the lesion has been excised. Many a times we come across young women with multiple fibroadenomas. What should be done? Excision? The answer is no, because there's no point in making multiple incisions and removing multiple fibroadenomas. What is important is to reassure these women, if it's not causing problems, there is nothing that needs to be done except for a follow-up ultrasound in a few months' time. This is the majestic Charminar in the old city, which is illuminated in pink. Phyllodes, this is something that occurs in older women. This is a mammographic appearance, large, rounded, oval, well-circumscribed lesion with smooth margins. And this is an ultrasound scan picture which shows a large, well-circumscribed, oval, heterogeneous, hypoechoic lesion with cleft-like spaces. What should be done? FNA? The answer is no. What should be done is an ultrasound guided core needle biopsy. And even with an ultrasound guided core needle biopsy, it's impossible to distinguish between a benign phyllodes and a malignant phyllodes. So the answer is a wide excision has to be done. And if it's very large, it may also need a mastectomy. This is the historic legislative assembly in Telangana, which is illuminated in pink. And I think this is the only legislative building in the country which turns pink in the month of October. Cyst, again common in women who are older, over 30 years of age. A typical history, sudden onset of noticing a lump. This is a mass lesion, which you can see on mammography. And this is an ultrasound scan picture, which shows that it's smooth, it's anechoic, with well-defined walls and enhanced through transmission. Very typical appearances of a cyst. What should be done? Should we aspirate every cyst? The answer is no. And if a cyst fluid is aspirated, should it be sent for cytology? The answer is no. When do you aspirate a cyst? Only when it is large, it's causing discomfort with signs of infection. And even after the cyst fluid is aspirated, there is absolutely no need to send it for cytology or culture sensitivity. Firstly, because it has no value. Secondly, it may show a false picture of atypia, which may lead to surgery, which is unnecessary. And of course, it's not cost effective. When should we send fluid for cytology? When the aspirate is bloody, or when there is a residual mass on ultrasound scan after aspiration, such as this. When we see an intracystic lesion here, then we not only have to send the fluid for cytology, we need to do an ultrasound guided core needle biopsy for this intracystic solid mass. This is the Consulate General of the United States of America in Hyderabad, which also turns pink in the month of October. Benign microcalcifications. Many a times we come across films which are referred to us, patients who come with reports saying there are multiple microcalcifications. There are numerous benign microcalcifications. In fact, 95% of the calcifications are benign. These are typical vascular calcifications. These are secretory calcifications, and these are oil cysts. What is to be done for benign microcalcifications? Nothing at all. There is no need for even a follow-up. A 28-year-old lady lactating, breast abscess. What should be the first treatment strategy? Should it be an incision and drainage? The answer is no. It should be an ultrasound guided aspiration. Many a times, these patients need to be brought every 2 or 3 days for repeat aspirations, and they must be commenced on antibiotics. A 32-year-old lady with galactosile, an ultrasound scan picture showing typical fat fluid level. What is to be done? Aspiration? The answer is no. Aspiration should only be done if the galactosile is infected. This is a mammogram which looks like a cancer, several mass lesions, pleomorphic microcalcifications, and when you do an ultrasound scan, you see multiple ill-defined cavities which are reaching the skin. The diagnosis is a breast TB, very often missed, very often badly managed. Many times, patients present with recurrent abscesses, non-healing ulcers. This is a typical picture. Many women undergo unnecessary surgery for TB breast. These are multiple incisions which have been made, multiple incision and drainages which have been done. The scars don't heal at all. What is to be done when someone presents with features suggestive of breast TB? An ultrasound guided core needle biopsy must be done. And if the histology shows features suggestive of chronic granulomatous mastitis with epithelioid giant cells and caseous necrosis, we presume this is tuberculosis until proven otherwise. Most of the times, the AFP will not be positive. And we have to explain this to the patient that sometimes in medicine, it's not black and white. There are gray areas, and tuberculosis is one such diagnosis. And once a presumptive diagnosis based on granulomatous mastitis with epithelioid giant cells and caseous necrosis is made, we always involve a pulmonologist. We explain the drugs that will be given on an empirical, the drugs are given for a short period of time. An empirical course of anti-tuberculous therapy is given for 3 months. We explain the side effects of the various medication. We take the patient into confidence and then commence the anti-tuberculous therapy. Many a times, trust me, this works. Every week, we get at least 2 patients with TB breast, and most of them get well with anti-tuberculous therapy, which is continued for the full course. It's important to remember not to do any harm. There are certain benign conditions, but in fact, they're not so benign. This is a 42-year-old lady who presents with spontaneous blood-stained nipple discharge. And basically, this is the mammogram, which shows a mass lesion just behind the nipple. And this is an ultrasound picture showing a lesion, which shows some vascularity. And an ultrasound-guided biopsy shows this to be a papilloma with an atypical ductal hyperplasia. What is ADH or atypical ductal hyperplasia? The cells in the ducts increase in number and develop an unusual pattern. They are discovered usually on routine core biopsy. They are associated slightly with an increased risk of cancer in the future. So when a diagnosis of ADH is seen on the pathology report, there is no option but to excise that focus to rule out cancer. We also come across atypical lobular hyperplasia. Cells in the lobules increase in number and develop an unusual shape and pattern. We also have something called pleomorphic lobular carcinoma in situ, which are larger, more abnormal cells, usually seen in older women. They are again routinely discovered on core biopsy. So, what is the future risk of these conditions? Atypical ductal hyperplasia or atypical lobular hyperplasia or lobular carcinoma in situ, they are not cancers. And the vast majority will never develop into cancer. But atypical ductal hyperplasia and pleomorphic lobular carcinoma in situ, there is slightly higher risk of developing cancer in future. And when such a diagnosis is seen on pathology report, it's mandatory to excise them. And it's important to counsel these patients. And there is an ongoing trial, a chemo prevention trial for where tamoxifen is given for 5 years, but it's not currently the standard of care. And currently, what is required to be known is that if there is a diagnosis of ADH, it doesn't mean it's a cancer, but it's important that that focus of ADH should be excised. This is a 45-year-old lady who undergoes routine screening. You can see a typical radial scar, which is seen on ultrasound scan as well. A radial scar is in fact not a scar. It's a hardened breast tissue. They are asymptomatic. They are usually seen on screening mammograms. And radial scar and complex sclerosing lesions are the same. They're identified by size. What is required is an ultrasound or a stereotactic core biopsy, and in fact an excision, because sometimes a radial scar can be associated with cancer. It's important to excise to rule out cancer. A 61-year-old lady on routine screening, a mammogram demonstrating a mass lesion or an architectural abnormality with some amorphous microcalcifications. Sclerosing adenosis is an extra growth of tissue within the lobules. They are often asymptomatic. They are seen on routine screening. The importance lies in the fact that it mimics cancer on mammogram. What is required is a core biopsy or in fact a stereotactic core needle biopsy. This is the Prasad's IMAX, which is one of the most popular places of entertainment in Hyderabad, which also turns pink in the month of October. The third component of my presentation is to outline some of the breast cancer management principles. Every year, 1 million new cases of breast cancer are diagnosed, and a woman loses her life to breast cancer every minute. In India, it's a tsunami with 162,000 new cases being diagnosed each year. It's the commonest cancer affecting women in our country because of lack of awareness and absence of an organized nationwide population-based screening program. More than 70% present in the advanced stages, and a woman succumbs to breast cancer every 10 minutes in our country. This is a mammogram showing a typical spiculated lesion in the left side, both the CC and MLO view. This is an ultrasound picture of the cancer, which shows that it is hypoechoic, ill-defined with post-acoustic shadowing. What should be done? Should FNA be done or an excision biopsy straight away? The answer is no. What should be done is an ultrasound scan guided core needle biopsy, which you can see on the left. And it's always important when there is a diagnosis of cancer to evaluate the axillary lymph nodes by an ultrasound scan. And if there is an abnormal lymph node, as you can see on the right side, an abnormal lymph node in the axilla, then an ultrasound guided core needle biopsy of the lymph node is always taken to ensure that we have an accurate diagnosis of the lymph node status as well before we institute treatment. 4 years ago, our Prime Minister launched the Digital India campaign. Usha Lakshmi Breast Cancer Foundation, which is based out of Telangana and Andhra Pradesh, in fact published information on every aspect of breast health in English and Telugu. And in 2017, the foundation launched the world's first mobile app on ABCs of breast health in 12 commonly spoken Indian languages. And this mobile app has every conceivable information about every aspect of breast health, both benign and breast cancers, which is explained in simple, easy to understand language, and it's freely downloadable in both App Store and Google Store. And this was launched by none other than Sri Amitabh Bachchan in 2017.
Dr. Raghuram, may I just offer my services, my voluntary services to this wonderful campaign? If in the future you would require to use my face and my voice towards this campaign, I shall be more than willing to help you. Thank you so much.
I'm not saying that this mobile app replaces counseling, but I can say for a fact that in addition to the counseling, this mobile app has helped many patients to deal with various aspects relating to breast cancer and benign breast disease. A word about screening. A typical question from a patient: I'm 43 years old and I have no lump. Do I need a screening mammogram? And the answer is yes. A screening mammogram helps detect breast cancer many years before the lady or the doctor can feel the lump and significantly improves survival. That's the reason why screening mammogram is advised. It's a myth that, again, patients say, if I have a screening mammogram, does it prevent breast cancer? The answer is no. And is screening mammogram effective in all ages? Again, the answer is no. It's only effective in women over 40. Annually must be done so that breast cancer can be picked up in very early stages, so early that we can ensure that they succumb to old age and not cancer. In this day and age of full-field digital mammography system and digital breast tomomammography, we're seeing a lot of screen-detected cancers. This is a 51-year-old lady who is presented with routine screening. A CC view shows a cluster of pleomorphic microcalcifications, which can also be seen on the MLO view here. What should be the next step? Should it be a wire-guided excision? The answer is no. So the patient does not need to have a wire-guided excision to get a diagnosis. A diagnosis can be obtained preoperatively with a stereotactic core needle biopsy so that treatment can be planned. Moving on to genetic risk assessment. A typical question: doctor, my mother had breast cancer. Am I at an increased risk? My grandmother had breast cancer. Am I at an increased risk? In fact, many people think that family history is the most important risk factor for getting breast cancer. And they come with this myth to the doctor's clinic asking these questions. And the fact is that the vast majority of women with breast cancer do not have a family history. And strong family history only accounts for only 5 to 10% of breast cancers. I'd like to point out the Angelina Jolie effect a few years ago. It's important as doctors that we remember that we do no harm. And Angelina Jolie's decision to have a prophylactic bilateral mastectomy was right for her. and it in fact achieved wide media coverage as a celebrity. And on a positive note, it increased the awareness about the genetic risk of developing breast cancer. But the damage that it has done is it has caused enormous anxiety amongst the worried well, particularly in a country like India, where we don't have genetic clinics and we don't have counseling. It's important to always remember that there's a fine line between advocacy and creating a scare. And getting a genetic test done just in case is not acceptable, because only 5% of breast cancers are hereditary. They carry the abnormal genes BRCA1 and BRCA2. And it's very important to understand what is significant family history. If there is one or more close relatives with breast cancers diagnosed under the age of 40, or two or more close relatives who have been diagnosed with breast cancer, or close relatives who have been diagnosed with breast cancer and ovarian cancer, or if there is a close relative who has had a male breast cancer, or in fact, there is a close relative who has had bilateral breast cancer. So when such a history is there, it's very important to, I'd like to emphasize here that counseling is absolutely crucial before getting the genetic test done, and the emotional drive to get the test done just in case should be resisted. Coming to staging for breast cancer, is staging required for the evaluation of early breast cancer? What staging tests should be done? Is PET-CT essential for evaluation of breast cancer? The answer is, for early breast cancer, there is no role for CT scan or bone scan or a PET scan. For a locally advanced breast cancer, what is required is a CT scan of the chest with contrast, including the liver, and a bone scan. And PET-CT is still no longer considered to be the gold standard, although if the facilities are there, in one test, one can evaluate both the liver, lung, and the skeletal system. This brings me to some principles relating to oncoplastic breast surgery, which combines oncological surgery with plastic surgical principles to ensure complete removal of the imaging abnormalities with clear margins and good cosmesis. Some basic things: when a lesion is excised, gone are the days when we leave a seroma to fill the wound. So it's very important to undermine the edges both at the subcutaneous level and at the pectoral fascia so that there is no defect in the breast. And placement of the scars is very important. This is a patient who underwent Benelli or round block technique for a lesion in the upper inner quadrant where there is very less breast tissue. And rather than making an incision on the breast in the upper inner quadrant, by doing a round block technique, which is centered around the nipple areolar region, one can achieve very good cosmesis. This is a lady who had a small focus of DCIS with a clip left in situ near the microcalcifications, as you can see. This is the guide wire in place, inserted preoperatively under ultrasound guidance at the breast center, and this is the lesion that has been excised. It's very important to achieve good cosmesis with oncoplastic breast conserving surgery techniques. I won't be going into too much detail about oncoplastic breast conserving surgery, but like to highlight what the godfather of modern breast surgery, Umberto Veronese, said. Women aware of breast cancer issues and to take part in early detection programs must be rewarded with gentle and appropriate care and not punished with heavy and often unjustified treatments. And sentinel node biopsy is surely a minimally invasive, accepted technique for the evaluation of lymph node status in women who present with clinically node negative disease, which is also negative on ultrasound scan of the axilla as well. Because the analogy is, after a crime, you don't interrogate a bunch of people who are 2 blocks away. You focus an eyewitness at the scene of the crime. But the major limitation with sentinel node biopsy is the fact that it requires radioisotope, nuclear medicine facilities, and so it's not feasible in a large number of facilities in our country. Is there an alternative? Yes, indeed, there is. Indocyanine green based sentinel node biopsy. Indocyanine green is a fluorescent dye, and in fact, it has been used very widely over the past 40 years in the evaluation of liver function, cardiac output, etc. And this is based on emitting infrared fluorescence. And there is real-time visualization of this dye, and the dermal navigation through the dermal lymphatics can be seen very clearly. It's very low cost. There is no need for radioisotope or nuclear medicine facilities, and it's very safe. How does the ICG work? When the indocyanin green is excited with light, it binds to albumin, which can be picked up with a special camera. What does the instrumentation involve? It's a fluorescence imaging system, a fluorescence probe, and an indocyanin green, which is 25 milligrams, which is actually diluted in 5 ml of distilled water. This is a patient with early breast cancer, node negative clinically, and ultrasound scan of the axilla did not demonstrate any abnormal nodes. This is a dual technique sentinel node biopsy using a blue dye and an indocyanin green. This is the blue dye being injected, 3 ml of methylene blue and 3 ml of indocyanin green. As soon as the ICG is injected, you can see the dermal navigation through infrared fluorescence, which is picked up by a specially designed camera. And you can see where exactly the lymphatic flow stops. And that is where the incision is marked. This is the patient on the table. The lesion is marked on the breast, and you can see a mark which is in the axilla, which shows where this lesion sentinel node is likely to be. And on making the incision, you can see the blue node, and that is the same place which is also, demonstrating an indocyanin green positivity with a specially held camera. And this is the setup, which is not very expensive. It is definitely affordable by many hospitals. And the recent European Society of Medical Oncology guidelines have said that indocyanin green can be considered as a technique for sentinel node biopsy. This is still being evaluated right across the world. To assess the accuracy of indocyanin green, the Association of Breast Surgeons of India will be conducting a multi-center prospective randomized controlled trial to assess the efficacy, the sensitivity, the specificity, and the positive predictive value of indocyanin green, which is very, very promising. Funds have been accrued, and Dr. Somshekhar, who is the president of the Association of Breast Surgeons of India, will be spearheading this prospective trial. And in a couple of years' time, we should come back to you with the results. So in operable primary breast cancer, all women undergoing evaluation must have an ultrasound scan of the axilla at the time of initial triple assessment. If there are abnormal nodes, then axillary node clearance is the way forward. But if the ultrasound scan of the axilla is normal, then a sentinel node biopsy or a blue dye assisted axillary node sampling can be performed. And if it is negative, then there is nothing to be done. If it's positive, if there are many nodes positive, then axillary node clearance or radiotherapy can be considered depending upon the multidisciplinary team decision. In conclusion, I'd like to emphasize that triple assessment is mandatory in the evaluation of any breast lesion. Communication skills have to be at your best. Most breast health issues which are benign can be managed conservatively, and management of breast cancer requires a multidisciplinary team approach. And your decision to think right, choose right, and do right will rarely, if ever, be the easiest course to follow. My heart beats for early detection, and I hope yours too. And finally, I'd like to take this opportunity on behalf of the Association of Surgeons of India to invite you to our flagship annual Congress, ESICON 2019, which is happening in December in Bhubaneswar from 18th to 21st. Please do come. This is new ASI, which promises creative leadership and accountable governance. The next webinar will be on the 20th of November, which will be delivered by Dr. Roy Patankar from Mumbai on tips and tricks in the management of hiatus hernia and GERD.
Prabhu, I've really enjoyed your talk as always. There are a few questions for you from the audience from across the country. The first one is by Dr. Sen. He asks you whether MRI breast is helpful in early and specific diagnosis of carcinoma breast. Is MRI breast helpful in early and specific diagnosis of carcinoma breast?
Yes, the answer is yes, and there are certain specific situations. This is particularly used in someone who has a high risk of developing breast cancer. As you've seen from my presentation, there were a few slides which showed what is significant family history. And someone who has significant family history, who is considered to be high risk for developing familial breast cancer, that is abnormal BRCA1 and BRCA2 genes, they are the kind of people who will be benefited with an MRI breast, because we intend to screen
specific diagnosis of carcinoma breast. Is MRI breast helpful in early and specific diagnosis of carcinoma breast?
Okay, can I answer this? Yes, I started this question.
Yes,
is it,
and there are certain specific situations. This is particularly used in high risk breast cancer. As you've seen, there were a few slides which show what is significant has significant family history, who is considered to be high risk for developing familial breast cancer, that is abnormal BRCA1 and BRCA2 genes. They are the kind of people who will be benefited with MRI breast, because
same thing is cutting. You could probably start now.
Can you hear me?
Yes, sir.
Right. Okay.
Yes.
The answer to this question is someone who has a familial risk of developing breast cancer, who has BRCA1, BRCA2 abnormality, we start screening at an earlier age. And when we start screening at an earlier age, we can't be relying entirely on mammography. In those circumstances, we alternate MRI 6 monthly with a mammography. So that is the first indication. The second indication for MRI in early detection of breast cancer is when there is a mammographically occult breast cancer. So you find something in the axilla, which is breast cancer, which is proven to be cancer. You do an ultrasound and an ultrasound guided co-biopsy, but your mammography has not picked up a lesion in the breast. That is when you call it a mammographically occult breast cancer. That is the second indication. And thirdly, MRI is used in women who have implants. When someone has implants, it's very difficult to do screening by way of mammography over the age of 40. In those women as well, MRI is indicated. But MRI should not be used willy-nilly in breast cancer screening, because it is not cost effective. And by definition, any screening test must, in addition to be accurate, sensitive, and specific, should also be cost effective.
Reconstructed breast, Raghu.
Yes, absolutely. Again, in a reconstructed breast, if there is going to be a mastectomy and reconstruction, the answer is no. But if someone has had a breast conserving surgery and she has had an implant placed, or she has had a partial like a mini LD flap, in those circumstances as well, MRI is very useful, because the accuracy of mammography is limited in those situations. When the breast is scarred, MRI role comes in a big way.
You talked about BRCA1 and 2 positive people. I would not call them patients then. What duration would you advise MRIs? The inter-MRI duration. Yes.
What we would do is we would alternate screening by way of mammography and MRI. Say if we do mammography now in the month of October, in April we would do an MRI, and then again in October we would do a mammography. But if the patient is very young and you're starting the screening very early in their 20s, then we would just rely on MRIs.
Wonderful. I think that should convince the Dr. Sen about role of MRI in early diagnosis of cancer of the breast. The second question comes from Sharad Daga. Persistent nipple discharge, greenish black in color, non-spontaneous. Ultrasound shows ductal in a 35-year-old lady. What would be the management plan? Persistent nipple discharge, greenish black, non-spontaneous. Ultrasound shows ductal in a 35-year-old lady.
Right. Here, the triple assessment has not shown, I presume, that there is any lesion in the breast, particularly in the retroareolar region. That is by way of mammography and ultrasound has shown that there is only ductal in this lady. The second point that you have mentioned in history being that it is not spontaneous. That means this discharge is occurring only when the lady presses the breast. So therefore, in such a situation, when we are confident that the triple assessment has not shown any lesion, and if this discharge is not bothersome, there is nothing that needs to be done. This discharge does not need to be sent for cytology because, as I mentioned in my presentation, it serves no purpose. Secondly, it's not cost effective. And most importantly, many a times our pathologists give a diagnosis of C3 in their reports. Then we are obliged to over-investigate unnecessarily for reaching no possible diagnosis. The only time we would be worried if the triple assessment shows that there is some lesion, intraductal lesion behind the areola, or if there is a blood-stained discharge. These are the only two situations when we would take this further. I would just reassure the patient, say to the patient that the triple assessment has not shown anything worrying, and as long as she does not panic and then keep on pressing in that area, we can ask her to be reassured and get her back and review her in about 3 months and repeat an ultrasound scan, more to reassure her than anything else.
Would a unilaterality and bilaterality change your management plan, Raghu?
Not really. If my triple assessment has not shown any abnormality, I would not be worried. But if the lady says to me, I'm bothered by this discharge and this is bothering me, then yes, this patient, if she has multi-duct ductectasia, then she requires a major duct excision. But I would veer on the side of conservative management in this lady.
Wonderful. I think that has been a very, very clear explanation about what to do, because these young patients are more worried than troubled by the condition. So it's more psychological than physical.
So essentially, the management principle involves reassuring the worried well. The vast majority of benign breast health issues require counseling, and it requires excellent communication skills and convince the patient that there is nothing to worry and nothing needs to be done except for a routine follow-up.
Wonderful. The next question comes from Prachi Gang. How is vacuum-assisted biopsy a treatment modality for fibroadenomas?
With the technological advances, now it is possible to excise a fibroadenoma which is of a reasonable size, not more than 3 centimeters. Normally, when we do a triple assessment and the core biopsy confirms that this is not malignant and it is fibroadenoma and fibroadenoma alone, my general way of speaking to patients is to show the picture of the ultrasound with the needle and the histology report to tell them that this is not a cancer, this does not require an excision, and we can safely follow it up, and we bring the patient back in 6 months for a repeat ultrasound scan of the breast to see if there's any increase in size. If there is no increase in size, we would again reassure her and bring her back for routine screening if she's over the age of 40 years. But in this day and age, there are a lot of patients who don't want the feeling of a lump in the breast. So our criteria, although we work in a private setup, is very stringent. We don't offer this on most occasions, but if the lady says to us that, doctor, I have a 2 centimeter lump, I don't want this, then rather than taking her to theater and excising this lesion under general anesthesia, much as I may place the scar, the incision in the circumarular region, it would still involve a general anesthesia, it would still involve some scarring. So this is a technique that has been described not only for excising indeterminate lesions. The vacuum-assisted core biopsy started off with excising indeterminate lesions or large cluster of microcalcifications, but this now can be extended to excising these fibroadenomas under local anesthesia, which involves a large gauge core biopsy, which is done under local anesthesia. And this is a machine that can be procured. It costs about 20 to 30 lakhs. And this can be offered as an additional armamentarium in the breast center, which we have started recently.
I think that's really clear about the role of vacuum-assisted breast biopsy. The next three questions come from Chandu Sagar Neelakantam. What should be the investigation after excision of malignant mass, like markers or IHC marking?
Yes. Whilst doing the triple assessment itself, we don't wait for excision to get these markers done. We would like to have a comprehensive diagnosis, not only of whether it's an invasive cancer or not, but we would ask for ER, PR, and HER2 status routinely on our core biopsy, so that we have everything on hand before we decide on the management based on a multidisciplinary decision. So we don't wait for an excision biopsy to get a diagnosis. And in this day and age, we don't do an excision biopsy to get a diagnosis. We always do an ultrasound guided core needle biopsy to get a diagnosis.
So I think that stresses the fact that for a primary diagnosis, you would need a core needle, never an FNAC.
Absolutely.
Yeah. The next question is significance of guided axillary lymph node biopsy in a case where who received neoadjuvant chemotherapy is required. Guided biopsy, neoadjuvant chemotherapy is required, and breast conservation is planned. Oh, I think it's like this. Ultrasound guided, chances of needle tract seedling while axillary lymph node biopsy is done. This comes from Prashant Nanavati from Vadodara.
Right. Our routine practice is when the breast lesion is assessed by way of triple assessment, when we do an ultrasound scan of the breast and do an ultrasound guided core needle biopsy of the breast lesion, at the same sitting, we always do an ultrasound scan of the axilla. Now, if the ultrasound scan of the axilla is normal and clinically normal, these patients end up having a sentinel node biopsy. But if there is an abnormal lymph node in the axilla, we would always do an ultrasound guided, ideally an ultrasound guided core biopsy. If we can't do that, and if the node is sitting very, very close to a major vessel, we do an ultrasound guided FNA to know whether or not the lymph node is involved. If the lymph node is involved, and suppose we are giving neoadjuvant chemotherapy, then we would monitor the patient. We would bring the patient back for an ultrasound scan assessment in about 3 months' time to see whether it's responding. And as you have seen in one of my presentations, there was a lady who presented, a young lady, a 35-year-old lady who presented with a locally advanced breast cancer. She had neoadjuvant chemotherapy. The tumor almost disappeared, so we had to do a wire-guided excision. But we did axillary node clearance for this lady because preoperatively the lymph node was positive. So therefore, we would elect to do a axillary node clearance, although there is a debate on whether you should do that. And there is also a debate, and there's also one view that one can do a sentinel node biopsy preoperative before starting the neoadjuvant chemotherapy. But the standard is that if someone has a node positive disease in a locally advanced breast cancer, those patients would require an axillary node clearance regardless.
Raghu, Dr. Ramanuj from Baroda again asks you to guide him in the management of premenopausal, low risk, palpable lump right breast, 1.5 into 1.5 centimeters, right axillary node negative FNAC negative, true cut biopsy is positive for DCIS, workup and management. So true cut biopsy is DCIS, axillary node FNAC is negative, size of the lump is 1.5 to 1.5 in a premenopausal lady.
So this patient, from what I can gather from the triple assessment, has a diagnosis of DCIS in a 1 centimeter palpable lump. So in such a situation, when we get a diagnosis of DCIS, there is no role for doing an FNA of the axilla in the first place. Perhaps on imaging, there was a presumptive diagnosis of an invasive cancer, and there was perhaps an abnormal lymph node in the axilla. So I don't know why the FNA of the axillary lymph node was done. But if there is a diagnosis of DCIS, then this patient just requires a wide local excision of the lesion in the breast, and we would await histology. And if the histology is in keeping with DCIS with a margin around the lesion, then there is no further surgery that needs to be done, and this patient would require adjuvant radiotherapy subsequently.
Would you use frozen section to avoid a second surgery on this patient?
We don't use frozen section for the simple reason that many a times, we get, over exaggeration or under exaggeration of the report. So we always wait for the formal histology. And when there is any doubt, if it's not palpable, we always do put in a wire and do a wire guided excision as well. If the lesion is very small, we always take a specimen X-ray to make sure that we have taken an adequate margin around the lesion.
So you wait for an early paraffin section to decide on what to do for this patient. Fair.
Yes.
The next one is much more interesting. It comes from Leo Taro from Father Muller Hospital, Mangalore. I think it's one of a place where you were also educated from a different college, but Mangalore, yes. Elderly patient, infiltrating ductal carcinoma, T1 lesion, refuses surgery. What is the treatment modality and management principles?
How old is she?
She is elderly, she said. Elderly.
Elderly patient, if a biopsy has been done, we would, as I mentioned earlier, we would do the breast panel, that is ERPR and HER2, presuming that she is ERPR positive and she's not fit for surgery or she refuses surgery. There is absolutely good evidence to show that in elderly people, we can commence primary endocrine therapy and keep them under close follow-up. And we always, when we start them on primary endocrine therapy, we obviously involve the multidisciplinary team, and with the assistance of the medical oncologist, we closely follow up this patient and we do an ultrasound scan in 3 months to assess the response. Although we must be aware that with endocrine therapy, the response takes longer than chemotherapy, but it does work. And in such patients, there is good disease control for a long period of time on primary endocrine therapy, particularly in elderly people.
Okay. The next one comes from Dr. Firdousi Ambikapur. What is the sign of healthy breast and how can one improve breast health? A bit of a social aspect of a scientific problem.
Right. Now, with regards to healthy breast versus unhealthy breast, there is no concept like that, but there is this concept of breast self-examination and breast awareness. And there is a lot of evidence now through randomized controlled trials that breast self-examination as a concept has been given up. And we have published on this in the European Journal of Cancer as well. And what is now the current view is that women should be aware of how their breasts look and feel. There is no specific time. For example, in self-examination at one particular time, women are asked to put their hand behind their head, on their hip, and examine in different positions lying down. This causes enormous anxiety. They become paranoid to the extent that they go to doctors and unnecessary procedures are done. And therefore, the concept now is women are encouraged to know how their breasts look and feel throughout the month, because the breasts change throughout the month because of the hormonal fluctuation. And the woman is the best person to know whether or not her breast feels different from what it was last month. And if there is any new change, like if there is a new lump in the breast, if there is any blood stain discharged from the nipple, if there is any recent retraction of the nipple, if there is any excoriation of the skin around the nipple areolar region, or if there is any dimpling of the skin overlying the breast, then she must report to a specialist. So therefore, women must be encouraged of all ages to be breast aware rather than encouraging self-examination. Now, with regards to the second component of the question, which is how can one improve breast health care? That is a topic in itself, because there are various aspects to improve breast health in our country, which has not been covered in my presentation, where the issue of breast health care improving is concerned. We have to focus our time and energy in dealing with rural India. That is where 70% of our population reside. The Pink Ribbon campaign, the so-called awareness campaigns that we do in cities as a foundation is absolutely a waste of time to do it in villages. In villages, we have to implement a screening program which is achievable, which we have actually implemented in Telangana and Andhra Pradesh. And this is now part of the national screening program as well. Clinical breast examination performed by a healthcare worker is the best way to detect breast cancer early in rural India. That is one way of improving breast health care, because 70% of breast cancers in our country present in the advanced stages. So we have to create the much needed awareness and reduce the incidence of women presenting in advanced stages. So this is one aspect that I will touch upon. The second is, of course, we have the Association of Breast Surgeons of India, which was formed in the year 2011, where we have brought together general surgeons, surgical oncologists, and plastic surgeons involved in the management of breast disease, so that they are better, networking, and they learn the latest techniques and advances in breast surgery so that they can deliver better breast health care to their patients. These are just two aspects that I've just touched on.
I think we have come to the end of the questions. Truly appreciate your efforts to bring healthcare to the doorstep of people and patients, Raghu. And then I think it's extremely important for surgeons all over the country to understand that breast health problems are increasing rapidly, and breast cancer itself is also becoming slowly a leading cause of cancer. And then the number of deaths that are also happening is steadily going up. So we are going the Western way with rapid urbanization. So I think we should be geared up to meet this challenge of numbers, challenge of delivering healthcare, not just for cancer, but all the anxiety that is associated with breast cancer, because once there is a lump, most of these young women think it is breast cancer. So I think we really appreciate ASI in selecting this topic and the speaker for this webinar. So the surgeons have to understand the efforts of the ASI, and more surgeons should log in to the Wednesday afternoons, the third Wednesday afternoons webinar that is organized by the ASI, sponsored by Healthium by a generous grant. Thank you very much, Raghu. Thank you, Healthium.
Thank you.
Thanks a lot, ASI, the President and the Governing Council members for having me in this webinar as a moderator. Thank you, Raghu, for that wonderful lecture, and then for answering our questions completely. Thank you.
Thank you.